This fourth edition of the educational webinar series held at Vijaya Diagnostic Center, Hyderabad. We have with us today the speaker, Dr. Geeta Jahagirdar, who's a senior consultant in the Department of Hematology at the Vijaya Diagnostic Center. Dr. Geeta has had more than a decade of experience in hematology and has a special and keen interest in the area of coagulation studies and assays. She has even conducted webinars, she has even conducted workshops in this area. No guesses on what the topic is? It's D-dimer for you. Over to you, Dr. Geeta.
Good afternoon, everybody. The topic for today's discussion, D-dimer clearing the haze. Historically, we have been measuring D-dimers as it is a biomarker of fibrinolysis in the diagnosis of venous thromboembolism and as a prognostic marker for pulmonary embolism and in certain other diseases. D-dimers are part of soluble fibrinogen degradation products that result from systematic degradation of vascular thrombi through the fibrinolytic system. So it is an indigenous, it is a marker of endogenous fibrinolytic mechanism. D-dimers are nothing but multiple peptide fragments derived from plasmin-mediated degradation of cross-linked fibrin. D-dimer serves as a global marker of activation of the coagulation and fibrinolytic systems. Before we go to the pathophysiology of fibrinolysis, let us primarily understand how the coagulation system works. As we all know, there is an extrinsic pathway and intrinsic pathway of coagulation which come together in converting the fibrinogen into fibrin under the activity of thrombin. This thrombin is converted into D-dimer by the action of plasmin. How this happens, let us have a look at it. So coming to fibrinogen, the fibrinogen is converted into fibrin under the action of thrombin. This fibrin is in the form of monomers initially. These monomers get cross-linked, forming fibrin polymers. These are cross-linked under the activity of factor 13A. The cross-linked fibrins molecules are under the influence of plasmin cleavage broken down into different sized fragments, mostly consisting of D fragments and E fragments. Two D domains or two D ends are released as one intact fragment known as D-dimer. Hence, we call it as D-dimers. So, D-dimers are nothing but the end products of plasmin cleavage of the fibrin, not of the fibrinogen. So, fragment D-dimers was used to describe final plasmin digestion products of factor 13A linked fibrin clot, which is a fragment of DDE. In the normal physiological conditions, 2% of fibrinogen is converted into fibrin, and instantly this fibrin enters the fibrinolytic pathway, and hence in adults there is always a small amount of D-dimer present. The plasma half-life of D-dimers is around 8 hours, which is much higher than the thrombin-antithrombin complex. Hence, the D-dimer level in the blood can be appreciated after intravascular thrombus formation. Coming to the significance of D-dimers, it is associated, increased levels of D-dimers are associated for conditions of deep vein thrombosis, pulmonary embolism, disseminated intravascular coagulation, malignancy, postoperative states, trauma, preeclampsia, liver disease, burns, infections, and thrombolytic therapy. Especially in the diagnosis of deep vein thrombosis, mostly negative predictive value is more important. It is in combination with clinical signs and symptoms. Deep vein thrombosis is diagnosed with the help of elevated level of elevated level of D-dimer in the bloodstream indicates deep vein thrombosis. The normal level of D-dimer in deep vein thrombosis is a negative marker. Further, apart from these pathological conditions, it is also increasing age and also in pregnancy. Throughout the pregnancy, as the third trimester approaches, there is an increase in D-dimer. Also, it is in the increased age above 50 years, it is noted that D-dimers are increasing. Hence, whenever a cutoff value is to be taken in adults, children, and in pregnant women, these have to be carefully studied. Coming to the clinical applications, as we all know, D-dimer value is useful in monitoring and titrating the anticoagulant therapy. It is further associated, higher values are further associated with recurring venous thromboembolism, and hence these kind of patients may benefit from prolonged prophylaxis. It is also useful in the differential diagnosis of acute aortic dissection in which the levels are markedly elevated acute coronary syndrome. D-dimers are also raised in atrial fibrillation. Normal D-dimer rules out DIC. However, the assay of D-dimers has got limitations. It is falsely elevated in patients with rheumatoid factors, and in whenever there is a concurrent use of heparin, recent trauma, post-surgery, and also in patients with icterus, it cannot be properly evaluated. Further, coming to the different kinds of assays that we have in evaluating the D-dimers. D-dimers are basically of two types. One is quantitative, another is qualitative or semi-quantitative. These qualitative or semi-quantitative are mostly card-based with latex agglutination as the principle. Amongst the quantitative type, we have different methodologies consisting of ELISA, CLIA or immunoturbidometry, and point of care assays. The ELISA methodology is, the TAT is 2 to 4 hours and it has to be run batch-wise. It is mechanical, laborious, and it requires lot of skill. Coming to CLIA or immunoturbidometry, it has moderate specificity. It also needs to be run in batches. It is automated and it is much less laborious compared to our ELISA, and the turnaround time is around 25 to 40 minutes, which is very important. Further, there are some point of care assays which can be used in the hospitals, which are readily available, and they use venous whole blood for the measurement of the D-dimers. These are highly specific and are and the D is of negative predictive value. There are different instruments available in the market today using these assays, and depending on the laboratory's requirement, they can be chosen. Coming to the important part of D-dimer assay, what are the different units by which it is assayed and what are the different instruments. There are a lot of instruments in the market which measure the D-dimer, and it is given out in the form of nanogram per ml, microgram per ml, or microgram per liter. And they are also measured in different units like DDU and FEU. If you look at the table that is here, it shows that there is a different cutoff value for each. And each time the clinician has to go through that for a particular patient, what is the methodology used and what is the unit used. There is no proper standardization. The units that are used are either FEU or DDU. FEU is mostly related to the mass of the fibrinogen and DDU relates to the mass of the D-dimer alone. Normally, FEU is almost equivalent to 1.75 times of DDU. However, FEU and DDU should not be interchanged. As per the recommendations of the CAP, these units have to be maintained what is given in the kit insert for that particular kit. as the direct extrapolation of these units is not straight. Hence, it is recommended that we do not change DDU to FEU in the general practice, which is normally seen in about 30% of the laboratories today. I would request all the laboratories to kindly take care of this, that they report in the same units as per the kit insert, as these are validated according to those particular units. Further, there is a lot of confusion because of this nanogram per ml, gram per ml, and these have to be kept in mind when treating the patient. There is no standard cutoff to the values of D-dimer because it is age dependent, and it also increases in certain circumstances like post-surgery, trauma, and also in patients who are elderly. Hence, it has to be taken care of when treating a patient. The standardization issues among different assays are because of the antigen present on different size degradation products. Monoclonal antibodies recognize different epitopes, and also different instruments have got different assay formats and calibrations are different. As you all know, when fibrinogen is broken down, we get lot of multiple peptide fragments. These multiple peptide fragments are of different molecular weight. D-dimers are specifically of these fibrinogen degradation products. There are some assays which have monoclonal antibodies which can identify them properly. However, some of the assays also identify the fibrinogen degradation products as D-dimers. Hence, there can be a lot of variation between two labs. Different point of care devices are also introduced, and they are highly sensitive in ruling out venous thromboembolism. However, they lack internal quality control, and hence caution is warranted. It is very difficult to standardize these assays, though it is the need of the hour, as D-dimers are reported by different methodologies and different units and by different laboratories. But it's a huge issue because there is no internationally accepted universal calibrator, which is leading to interlab variations. Hopefully, in the coming years, we will be able to standardize these. Coming to variations in the results of D-dimers, this is mainly again, as for any other lab parameter, it is dependent on pre-analytical errors mostly. Pre-analytical errors again constitute about 60 to 70% of the errors in the laboratory. Initially, it all begins with the sample collection. The more of the needle has to be between 19 to 22 gauge, and the anticoagulant that is used has to be citrated anticoagulant. Heparin interferes with the measurement of D-dimer. All should not be used. These vials which are collected, it has to be seen to it, like for any other coagulation assay, that transportation in time is necessary. These samples are stable for up to 8 hours at room temperature, and they stay stable up to 24 hours between 2 to 8 degrees centigrade. Further, if a sample has to be stored, it has to be, and then the plasma has to be separated and kept at minus 20 degrees centigrade, which can be used for few weeks to 1 month. Further, the centrifugation has to take place properly with a proper speed and for proper time. And when we store the samples for a very long time, freezing and thawing should not be done, which will cause erroneous results. Coming to analytical challenges, the detection of, as I already mentioned, because there in the pool there are already fragments which are not only the fragments of fibrin, there are also fragments from the fibrinogen. Hence, we have to select an assay which identifies the D-dimers alone. Also, we must keep in mind that ELISA is time consuming and it is run only in batches. It needs expertise. CLIA and immunoturbidome assays are better, that it can be run in batches and there's a rapid turnover, but still they have moderate specificity. Also, the sample type has to be very proper for the CLIA and immunoturbidimetry assays, where it should not be hemolyzed, icteric, or lipemic. Further, the point of care devices, though handy, do not have internal quality controls, hence they should be used with caution. Now, coming to COVID-19 pandemic, suddenly there is an uproar about D-dimer, and we have lot of clinicians ordering D-dimer tests. That is because there is an abnormal coagulation happening in the COVID patients. Abnormal coagulation, including raised D-dimers levels, is seen in disease progression of SARS-CoV-2 patients. PT may also be raised. Study shows that higher levels are associated with higher mortality. Rates above 1000 nanogram per ml at admission are more at risk. It's a biomarker which keeps increasing with the severity of the diseases and has been seen to decrease as soon as the infection decreases, along with HSCRP, which is an inflammatory marker. Now, the diagnostic value for thrombus formation is unclear. At what level should we be cautious? At what level should the anticoagulants should be used to prevent thromboembolism phenomenon is left to our clinicians. Coming to the pathophysiology of D-dimer formation in COVID-19 infection. There are three different theories that are explained. One is dysregulation of urokinase pathway. Second is involvement of AC2 receptors. Third is endothelial damage. As we all know, urokinase helps, it stimulates the plasmin to degrade fibrin to fibrinogen degradation products. So urokinase, whenever it is increased, there is an increased amount of D-dimers in the plasma. Next is involvement of AC2 receptors and endothelial damage. Let me try to explain this through a diagram. So initially, as we all know, the virus, that is the SARS-CoV-19 virus, tries to attack the AC2 receptors, that is angiotensin converting enzyme 2 receptors, which are mostly lining the lung, kidney, intestines, and the vasculature. So when it gets into the endothelium, it damages the endothelium, and also it also releases lot of inflammatory lot of pro-inflammatory cytokines. Lot of inflammatory reagents are released into the body, which further causes vascular inflammation. And also there is a rigidity in the blood vessel. And because of all this, the collagen of the endothelium is exposed, and there is lot of attraction of von Willebrand factor, selectin, and other platelets to that site, which causes abnormal clotting, and small sized vessels are occluded. So this is the primary thing that is happening, that it is leading to small vessel thrombi. Again, if the severity of the disease increases, the platelets are hyperactivated, they are consumed, which leads to thrombocytopenia, and it leads to bleeding. So basically, there are both hypercoagulability and hyperfibrinolysis happening at the same time in COVID-19 infection. So this is again represented diagrammatically, where we see that in the initial stages, there is an abnormal clotting where there is increased fibrinogen and VVF, and there are a lot of collected, and it causes abnormal clotting. D-dimer is slightly rising. As the disease severity increases, the D-dimers also increase greatly. The fibrinogen level in the body comes down, but the D-dimer level keeps on increasing. There is a lot of studies are done post this first episode of COVID pandemic, in which they have seen that there is a D-dimer elevations are increased with severity of the infection. They are seen in about 3.75 to 68% of COVID-19 patients. More than 1000 nanogram per ml is one of the risk factors for mortality in adult patients with COVID-19. However, role of D-dimer in COVID-19 patients has yet not been fully investigated. These are only hypothetical theories where we are suspecting coagulation and hyperfibrinogenesis occurring simultaneously. Okay, these are some of the studies which we have come across, and I have taken it from the research papers, where it says that more than 1000 microgram is more than 1000 nanograms per ml is causing more of mortality. Then it also says that more than 2.5 milligram per liter then is a disease mark, is a serious disease marker, and they suspect the prevalence of venous thromboembolism in patients with severe novel coronavirus pneumonia. The D-dimer levels are between 1.5 through 3.0 milligram per ml. So these are some of the statistics that we have got. Out of all this, I think we understand one thing, that the D-dimer levels constantly increase with the severity of COVID-19 infection. I think this is an interesting slide. I'd like to conclude with this. So when will the D-dimers come back to normalcy? So we have seen that some of the studies have shown that 25.3% of the patients had D-dimer values higher than 500 nanogram per ml, which is taken as the normal limit, up to 4 months after diagnosis. So it is not immediately after the infection has come down, but it has taken about 4 months to come back to normalcy. 8% of patients that were assessed during recovery phase had D-dimer levels more than twice the upper of the normal. 90% of convalescent patients had other coagulation and inflammation markers return to normal levels. Thank you very much. Before I end the session, I think I have 2 take-home messages. One to my colleagues, pathology colleagues, to not to change the units that are there in the kit insert and create our kits properly, and to the clinicians to kindly note the methodology and to serially stick to one particular methodology and units so that the patient can be properly monitored. Thank you very much.
So thank you, Dr. Geeta. That was an excellent and lucid presentation of this particular test, D-dimer. And it has, and given the current scenario of this pandemic, it has definitely gained a lot of importance and very relevant to the day today. And definitely needs more deliberating upon, considering the confusion that is there regarding the units. And you have very well summarized it, that units should never be changed from what is advised in the kit insert, because you can see the varying number of kits that are available, the different instruments that they are done on, the tests are done on. So an FEU as advised in the kit should remain as an FEU, and a DDU as advised in the kit should remain as a DDU. Also, the unit, that is the nanograms and micrograms, should never be interchanged and should also be given as per the kit. So, dear friends, we are ready for any questions. I think we already have some questions here. Dr. Geeta?
Yes, ma'am.
We have Dr. Rao asking how to choose among the various D-dimer tests available. How does one choose?
Yeah, true. That's a big challenge. Actually, the tests that are available in the market are of varied methodologies and varies units. But what has to be kept in mind is there should be a quick turnaround time, and the repeatability should be good, and kit should be validated properly according to different assays. The need of the lab, it has to be chosen depending on the number of samples that we are going to get, and also the stability of our samples, how long we are choose a rapid turnaround time, and there should be the good sensitivity and specificity in evaluating D-dimer.
Thank you. The next question by Dr. Vikas Chaudhary is one-time testing enough for any clinical decision, or serial sequential testing is required during the course of the disease, COVID-19?
Yeah, as we all know that initially whatever testing is done is only taken as a baseline marker, and definitely serial testing is advised, because as the disease progress, we have seen that D-dimer also progresses. So certainly it is an indication of progression, and even in convalescence, we have to keep in mind that it's a marker of coagulation abnormality. Hence, it has to be serially monitored to see whether the patient should be put on anticoagulants, whether prophylactic or therapeutic, depending on the decision of the clinician.
So the next question is by Dr. Swarna Bala. Kindly advise the appropriate timing to do markers or D-dimers after testing positive. I think this is similar to the previous question, but you can further clarify.
Yeah, as soon as the patient is COVID positive, we have to have a baseline, because as we all have seen, there is a lot of false positives in it. Either it is because of the age or the status of the person, like a pregnancy or post-trauma or surgery, whatever it is. So we need to have a baseline, and further a serial testing has to be done depending on the condition of the patient. And especially more so in hospitalized patient, it is advisable to do if, so that they can think of anticoagulating, adding anticoagulants to the therapy.
Dr. Pramod would like to ask you, as per the, should the D-dimer be considered one of the important biomarkers or not?
Yes, they should be.
Definitely,
They
yes.
should be. D-dimers are higher even after recovery. Yes, we have seen that there are certain studies which are showing. So in those patients where D-dimers are higher even after recovery, they have to be monitored so that they don't land up with thromboembolism episodes.
So as we see, it is not only a diagnostic marker, it is also prognostic, because it indicates the severity of the disease. So the lowest cutoff among the high values is 1,000 nanograms per ml. That is what has been seen in most of the studies. 1,000 nanograms cutoff for a worse prognosis in patients at the time of admission. However, there are studies with high values also as cutoffs, but it indicates that there's definitely a prognostic value to this test, including the diagnostic value. Any other questions from the audience? I think we... Yes, and Dr. Pramod also agrees that as per data presented, D-dimer can be higher even after recovery, which is, yes, just like our last slide showed, it needs to be monitored even after recovery and discharge of an admitted patient, definitely. Any further questions? Anybody would like to put in their any information that they might have got on the D-dimer, which we can pass on to our clinician friends and colleagues? I think there are no more questions, Dr. Geeta.
Yes,
so thank you once again for this excellent presentation. Very clear, and you have completely gone through the entire story of D-dimer, and hope to see all soon again after 2 weeks.
Thank you.
Thank you very much.
Thank you.